without further ado, we'll go to the interview with Dr. Miller.
Thank you for joining us.
Thank you for having me.
I just wanted to start out by asking, what was the prompting for you and your colleagues to perform this study, and what were you expecting what was your working hypothesis with this?
So this was a study I worked on when I was a resident, and this was led by one of my mentors in residency, probably my main mentor, Dean Lorich, who many of you know and have been influenced by. So basically, Dr. Lorich had started doing some vascularity studies with the femoral head a couple of years before this, and I was involved in that also. And what he found was the MRI techniques they were using at the time at Hospital for Special Surgery were really advanced and, kind of on the cutting edge of MRI use in the country. So we thought maybe if we look at these injuries that have a really high rate of avascular necrosis, like femoral neck fractures, talus fractures, we may find other vascularity maybe to help us learn what we need to protect more. But also our hypothesis was actually that we would see more than what we've traditionally learned from the textbooks. And the reason for that is most of the older studies are like the latex injections, where you can kind of see the arterial supply to the bone and dissect it out, but it's not very, very high resolution because you have to get the latex into those vessels. So what we learned on the femoral neck study, or the femoral head study, is that we were seeing a lot more kind of unnamed vessels, really tiny vessels that probably give a lot more vascular supply than we originally gave credit in that area. So our hypothesis really was that we would probably find more than what's traditionally been described, and then maybe give us some answers on why not every talus that gets a neck fracture goes on to avascular necrosis.
Awesome. And with the results of what you found, how has that changed what your mentors did and what you've done in your practice with respect to talus fracture care?
I don't think it has made a huge difference in everyday practice. I think the biggest thing is to help us just understand that there is more than just the traditional kind of two areas of blood supply, and that a lot of the blood supply comes from the posterior. So one thing that I would definitely try not to do is really dissect all the way around the talus, and we rarely have to do that. Sometimes when you're doing the medial and lateral approach, you may see that it goes across because of the trauma, but the only time I've really had that concern is when we've had some irreducible talus, and then you're really trying to get around and figure out what is keeping it from being reduced. And I try to be very wary of, completely cutting off all these great collaterals that you can see in the figure from the paper. The other thing that I learned just doing this actual study, we did the injections, we did the MRIs, and then afterwards we dissected out every single talus and actually pulled them out of the cadavers. And I found it very interesting that you could ever have an extruded talus, because it is impossible to get those things out. It would take forever to cut every little connection that's holding the talus in place, and it was shockingly hard to get them out. So whenever I see a dislocated talus or an extruded one, I always think back about how hard that was to get out. So it is interesting. So I would just say, back to your question, not a significant change, but just to be continuously very careful with the dissection, but also to know if you get in there and it has already been completely destroyed, underneath the talus, like where we normally think of the blood supply, or in the sinus tarsi, we're not, giving up on that patient. They can still have a significant blood supply from the posterior in particular.
I guess the scenario that comes to mind is if you have a patient with a talar neck and or body that you would fix from an anterior dorsal dual approach as a medial and lateral, but someone who also had a significant posterior medial or posterior fracture, would that give you pause on doing a third approach, a posterior medial approach, and saying whether you would try and perform reduction of fixation through some anterior base means or percutaneously only? Like how do those injuries, I know they're more rare than not, but how would you approach those in the setting of this?
Yeah, I definitely think that's a great question. Again, rare injuries, but for me, I definitely think if you can, at least try to preserve one area of the blood supply. So, which probably in that case, it would be whichever one is more displaced, you would have, some idea that that's probably the more disrupted blood supply. So maybe if the neck's more displaced, you're doing your regular 2 standard approaches, and then you maybe try to do percutaneous clamps or something else for a posterior part. But yeah, I would definitely try not to dissect all the way around if possible.
Is there anything with having done this study, is there anything that you, in retrospect, or your colleagues would have done differently, or that you've seen done in subsequent cadaveric studies looking at vascularity?
Yeah, I think the one thing I would really like to do, not that we would do it differently, but kind of part 2, or maybe even the more interesting part of the study would be to do it in patients who actually have a fracture. Either an actual patient with a fracture would be pretty challenging to get that, protocol done before you're trying to get them fixed. But even, doing a cadaver study, but where you do an osteotomy of the talus and then inject it and see where the contrast or fluid goes and see, how that disrupts, like doing a pre and post osteotomy kind of study, I think would be really interesting to kind of prove that blood supply, and maybe even see how the circulation or the collaterals change that blood supply after the osteotomy occurs. I also think it could be interesting to do a similar study after you fix the fracture. So in a live patient, if you did a study where you did these MRIs after the fracture was fixed to see what the circulation is, does that predict whether it's going to get AVN or not? Studies like that I think would be interesting. I think there are a lot more future studies that can be done, but I don't think there's a lot more to this. There is a paper that we published. There's one of the figures is the same from Foot and Ankle International in 2010. And we actually wanted to publish this paper first, but it just, with the editorial manager and everything, the other one just happened to get published first. So the figures got a little confusing during that time. But the other one is really looking more at the arterial anatomy itself. And I think the combination of those really kind of covered everything we wanted to with these studies.
For you, when you have these come in talar neck displaced fractures with associated dislocations or other extensions, what are your first things that come to your mind when you're teaching the residents and fellows in your institution?
Well, I think the first thing is obviously to get the patient reduced. For us, it's always kind of controversial about, do they need an X fix, or how urgently do you need to get the fracture fixed? I think in general these days we all agree that the best fracture fixation is probably going to give you the best outcomes as opposed to the fastest fracture fixation. So we're not generally doing these, in the middle of the night unless it's an open something or something that's irreducible. But that's kind of the thing we really try to teach the residents, is that we're trying to get the best fixation. And we definitely harken back to Dr. Vallier's landmark papers often to talk about, the AVN rates after these kinds of injuries, and just letting the patient know how severe the injury is, and that really the original displacement is probably the biggest predictor.